Hello everyone, myself Dr. Rachana, Associate Professor in the Department of ENT at Reddy Medical College for Women's in Hyderabad. In today's learning session, I shall enlighten you about epistaxis, which is one of the most common emergencies reported in the casualty for ENT. The objectives of this learning session are enumerate the causes of epistaxis, compare the two types of epistaxis, describe the different techniques of epistaxis management, and interpret the cause of epistaxis from history and examination. And lastly, demonstration of the nasal packing technique. Basically, epistaxis is a Greek word which means bleeding from inside the nasal cavity. It's a surgical emergency. It's not a disease, it is a sign. It can be seen in any age group, but in generally it is common among the age groups 15 to 25 among the youngsters, and in elderly in between 45 to 65 years are most commonly affected. Let's see the causes of epistaxis. So we shall classify the causes into three. It could be general causes, it could be the localized causes confined to the nose and the nasopharynx, and it could be idiopathic, which is majority of the cases it is idiopathic, where the cause is unknown. Coming to the general causes, firstly chronobiology. So any changes in the weather, uh, it's more common in the summer seasons because of the dried weather condition. And why it is common, we shall see in the coming slides. I shall explain you in the pathophysiology. Then diurnal variations. It could be changing with the weather conditions and in high altitude because of the pressure changes. Then CVS, that is the cardiovascular disorders. So the commonly seen in hypertensive patients, patients with mitral stenosis, pregnant ladies, and also in the tumors of mediastinum. Coming to the nutritional causes, the malnourished child or the adult, alcoholic abuse patients, vitamin A, D, C, E, and K deficiencies. Physiological cause, vicarious menstruation can result in epistaxis. Any bleeding disorders, it could be hemophilia, thrombocytopenia, leukemias, purpurias, von Willebrand disease, polycythemia vera, multiple myeloma, aplastic anemias, and any coagulopathies. It can be congenital or it can be acquired. Blood vessel disorders, arteriosclerosis, collagen disorders can result in epistaxis. Liver disorders, cirrhosis, and renal disorders, chronic nephritis and renal failure can result in epistaxis. Drugs. So mostly we see the people who are on the coagulants, uh, anticoagulants, and NSAIDs. So coming to this drugs, anticoagulants. So in order to prevent the blood from clotting, especially the people who have undergone the stenting or who are a known case of coronary artery diseases, they are prescribed these anticoagulants like ecosprin and clopidogrel. So most often it results in epistaxis. Certain infections like exanthematous fevers, measles, influenza, varicella. It could be malaria, typhoid, parasitic infections, Kala-Azar, viral dengue fever, and infectious mononucleosis by Epstein-Barr virus. So these are few infective causes, the generalized causes of epistaxis. Coming to the local causes of the nose and the nasopharynx. So in the localized causes, let's begin with the congenital causes. Unilateral choanal atresia. So choana is basically the posterior end of the nasal cavity. So if there is any choanal atresia, narrowing Either it could be partial or complete. It is one of the causes for epistaxis. And meningoceles, encephaloceles, nasal gliomas, all these are also some of the causes for epistaxis. The most common of all, the trauma, nose picking, injury to the nose in road traffic accidents, or could be face or skull base, could result in epistaxis. Iatrogenic. So, in certain post nasal surgeries of septoplasty, turbinectomies, or even maybe FES can result in epistaxis. Chemical traumas with arsenic, mercury also could land up with epistaxis. If somebody is having a very violent sneeze, the one with allergic rhinitis, so it leads to forceful blowing of the nose in order to, clear their nose, they tend to blow forcefully. So that's why in post nasal surgeries, we advise the patient not to sniff or blow the nose because it can result in epistaxis. Neoplastic conditions like hemangioma, inverted papilloma, these are the benign conditions. And even any malignant conditions of the nose and PNS, that is the paranasal sinuses, also could result in epistaxis. Certain drugs, like the nasal steroid sprays, which we prescribe in allergic rhinitis patients, could result in epistaxis as their side effects. And the drug addict patients, the sniffing of cocaine could result in epistaxis. Infective causes of the nose, to that matter, it could be either vestibulitis or sinusitis or any rhinosporidiosis, deviation of the nasal septum could result in epistaxis. So, granulomatous conditions like atrophic rhinitis, rhinosporidiosis, rhinoscleroma, and the chronic granulomatous conditions like TB, syphilis, leprosy, and vaginous granulomatosis and sarcoidosis could result in epistaxis. Foreign bodies, either live or non-living. So the live ones, that is the maggots or the leech, could result in epistaxis as they tend to burrow into the nasal mucosa. And a non-living one, that is a rhinolith, a stone formation in the nose, could result in a foreign body sensation, feeling, and it can land up the patient in epistaxis. To that matter, any vascular anomalies can also result in epistaxis. And a DNS with spur, as already mentioned. So because of a spur, spur is basically a sharp angulated projection from the nasal septum towards the turbinate. So this tends to irritate the nasal mucosa and it can land up in epistaxis. In nasopharynx, adenoids or a benign tumor, that is the juvenile nasopharyngeal angiofibroma or the carcinoma of the nasopharynx, could lead to epistaxis as well. Certain syndromes which are associated with epistaxis are Osler-Weber-Rendoy syndrome, von Hippel, Sturge-Weber, and Hermansky-Pudlak. A few briefing points about Osler-Weber-Rendoy disease. It's also called hereditary hemorrhagic telangiectasia. It's basically an autosomal dominant syndrome, and few clinical features include the telangiectasia of the dorsum of the tongue, oral cavity, lips, palate, nasal mucosa, and also the buccal mucosa. It's common at the pubertal age, and other systemic involvement includes that of lung, liver, and also the GI tract AV malformations. The treatment for this would be regular iron therapy and the laser therapy. Now let's see. Till now we have seen what are all the causes for bleeding. Now let's see what is the commonest cause depending on their age group. So let's say in children. So these children often have this habit of nose picking. This leads to the digital trauma in the little's area, the anteroinferior part of the nasal septum, which is the commonest site for bleeding. Because here there is a arterial plexus called Kieselbach plexus in this little's area, where there are four vessels which anastomosis. So let's see in the coming slides about those vessels in detail. So it is the nose picking, the commonest cause for bleeding in children. In the adolescent age, that too in a boy, the most commonest cause of bleeding would be a juvenile nasopharyngeal angiofibroma. In the adults, unless until they have hypertension, if they have the hypertension, that is the most common cause of bleeding. If they are non-hypertensives, then it is the malignancy. Now, there are two types of epistaxis. It could be anterior epistaxis, it could be posterior epistaxis. So let's see the differences. So anterior epistaxis, in incidence, it is the most common when compared to posterior epistaxis. And because it is anteriorly bleeding, so the localizing the site of bleeding is also very easy when compared to posterior epistaxis. Anterior means basically we have a landmark. It is anterior to the opening of the maxillary sinus. And the posterior to the opening of the maxillary sinus comes under the posterior epistaxis. The commonest site in anterior epistaxis would be Little's area, which is an arterial plexus. The posterior epistaxis, the commonest area being the Woodruff's plexus, which is a venous plexus. The age group, it's the children who are commonly affected for anterior epistaxis, and it's basically the adults for posterior epistaxis. The commonest cause for anterior being trauma. In posterior, it is the hypertension. Anterior epistaxis is mild in nature, whereas the posterior is very profuse, leading to airway compromise. Because it is anterior bleeding, the localization is easy, and hence it is treatment also is easy to manage the case, either with a pressure or with a cautery or with a nasal pack. Since posterior epistaxis, identifying the location is difficult, so it requires hospitalization, little difficult to control. We might need posterior nasal packing or take the help of a balloon catheter. On examination, in anterior epistaxis, the postnasal area is normal, whereas in posterior epistaxis, it's the posterior bleeding, and hence the postnasal, you can see the blood streaks or the blood flowing. Coming to the picture, so hence you can see the anterior bleeding where the blood flows in front of the nose when the patient is in sitting position. Whereas in posterior epistaxis, the blood flows back into the throat and hence the patient tends to swallow it. So there is a whole possibility of aspiration of the blood, and that can lead to sometimes a coffee colored vomitus. Now that we have seen the different types of epistaxis, we need to note different sites in the nose from where it can bleed. As already discussed, it's the Little's area, the arterial bleed, commonest site. And then retrocolumellar vein, a vein which runs vertically just behind the columella. Okay, and this vein, it crosses the floor of the nose, leading to venous bleeding in the young. Woodruff's plexus is basically a venous plexus which is seen in the posterior end of the inferior turbinate, and hence this leads to posterior epistaxis. The other sides being, above the middle turbinate is one of the commonest sites, sometimes even below the middle turbinate. In general systemic disorders, it's a diffuse bleed. There's no particular site. There's one area called Brown's area. Basically, it is behind the nasal septum, the posterior part, which is common in hypertensive bleeds. There's another thing called septal turbinate, which is another commonest cause of bleeding. So these were few sites. The commonest sites that you need to remember is, of course, the Little's area and also the Woodruff's area and also from the Brown's area posterior part of the nasal septum. And also the sphenopalatine area, which is right behind the middle turbinate. So coming to the Little's area, so what are the four vessels that constitute this Little's area or the Kieselbach's plexus are, these are the three arteries, basically the branches of the external carotid artery. So from the facial artery, we have the septal branch of the superior labial artery. And from the maxillary artery, we have the greater palatine artery. And from the maxillary artery, we have the sphenopalatine artery. So that's going posterior to the middle turbinate. And from the internal carotid artery, we have the ophthalmic artery, and which divides into anterior and posterior ethmoidal artery. So it's only the anterior ethmoidal artery which is contributing to the Little's area. So these are the four vessels: superior labial artery, greater palatine artery, sphenopalatine artery, and the anterior ethmoidal artery. Okay, next. Yeah, Woodruff's plexus. So it's basically behind the posterior end of the inferior turbinate. We have this venous plexus, which is called the Woodruff's plexus. Why nose is the commonest site for bleeding? It's because it has got a rich blood supply supplied by both the internal and the carotid, external carotid arteries. So there is various anastomosis between the arteries and veins. And moreover, these blood vessels, they run under the nasal mucosa unprotected. So because of which the contractile elements are not there. So that is why when they rupture, it tends to bleed immediately. Let's see the pathophysiology of epistaxis. Now that we have seen the causes, so let's see the causes: trauma. So how trauma leads to bleeding? It damages the blood vessel. So when the blood vessel is damaged, it will rupture and it will lead to bleeding. Next. So whenever patient is having any sneezing or a violent expiratory effect, there can be a sudden rise in pressure among the blood vessels leading to rupture. And then another is DNS, that is deviation of the nasal septum. So if the septum, that is in the midline, if it is deviated to one side, so what happens? The airflow is disrupted. So if there is disruption of the airflow, that area, it leads to dryness of the mucosal secretions of the nose. So the dryness will lead to irritation. Irritation, what do we do unknowingly, either in children or in adults when we are sleeping? So because of irritation, we tend to prick the nose. That can result in bleeding again. Okay. Little's area. So because it's a highly vascular area, it easily tends to get dried up. That dryness comes with the inspiratory current and easily traumatized, easily accessible area for the finger. So earlier we have seen the weather conditions, the dry weather is the most commonest in summer season in children. They tend to bleed a lot because of the dryness. So then why in cold weather there should be bleeding? So we in southern states might not experience that much cold weather in our country, but the northern states where there is a cold wave, they tend to take help of the heaters. So heating will lead to dehumidification of the nasal mucosa. So again there is dryness of the mucosa which leads to irritation. Irritation will lead to finger pricking leading to bleeding. Next, infections. So how do infection lead to bleeding? Definitely infections lead to inflammatory cells will accumulate in the area. So there is inflammation of the mucosal membrane. Because of this, the mucosa is damaged, leading to exposure of the blood vessels. From there is bleeding. And in vitamin and clotting factor deficiencies, basically the capillary wall itself is weak. So they don't have that contractile elements. So because of that, it leads to bleeding. And in atherosclerotic plaques, so what happens in a plaque? The muscle layer in the tunica media is replaced with fibrosis. So it reduces the constricting ability of the vessels, leading to bleeding. So These were few pathogenesis in different causes, how it leads to bleeding. Now that we know the cause, we know the different types of epistaxis, now and the pathophysiology of the bleeding, we should be able to properly evaluate the case when it comes to our OPD or casualty. So, how do we evaluate? So, to properly evaluate, first we need to stabilize the patient. So, if the patient is actively bleeding, we cannot ask history. Our first thing would be ABC: airway, breathing, circulation. So, once we stabilize these aspects, then we have to properly evaluate. Why evaluation is important? To come to the proper cause of the bleeding. It will help us in a better management. Once, if we don't know the cause and we just try to control the bleeding, it is of no use. Patient will repeatedly come to casualty with the similar complaints. So once we are able to know the proper cause, we would help the patient in a better way. There plays the role of history. So, when we take the history, we have to first note the mode of onset. How did it start? It started on its own, or was there any trauma? Next, how long, duration, how frequent, and then amount, how much amount, and then the side of the bleeding, which side it is, and then in the side also, which side, anterior, posterior, and then past. Were there similar complaints in the past? So, next, any bleeding tendencies in the family. Okay, so there are some syndromes, certain diseases that run in the family. And then, next, any history of nasal trauma, any URTI, upper respiratory tract infections in the recent times. Then, we have to rule out all the causes that we discussed: general, local, and then idiopathic. So generalized causes, we should know if there's having any history of hypertension, any liver disorders, any renal disorders, any cardiovascular disorders, and drug intake. As mentioned earlier, and there are they on any blood thinners like ecosprin, clopidogrel, or NSAIDs, which can lead to bleeding. So we have to take a proper drug history. Coming to habits, alcohol addict, or are they having any drug addiction, sniffing of the cocaine. So all this should be asked in the history. Once the history is taken, then now we have to examine the patient. So coming to the examination, so we'll check for the vitals. So in the vitals, definitely we cover the blood pressure, pulse rate, all the hemodynamic stability is taken care. So if suppose the patient is actively bleeding, so A, B, C, so we have to make it a point also to secure an IV line immediately. That is very important. So that we have to start with the fluids. If needed, even blood transfusion at times. Very rarely it is fatal, but sometimes we might need. Then properly we need to do the ENT examination to know the site of the bleeding and the systemic examination as well. So coming to the nasal examination, so first we go with the anterior rhinoscopy, wherein we see the anterior part, how is the septum, how is the turbinate, how is the floor, how is the roof of the nasal cavity. Then posterior examination. So posterior examination we can do with the diagnostic nasal endoscopy. So this examination of DNE, which is called diagnostic nasal endoscopy, we need to first anesthetize the nose with a local anesthesia. So we can take a nasal pack, soak it with 4% xylocaine, and also add few drops of decongestant to it so that we can properly localize the site. Any clots, if present, we can take help of a suction to clear it out. Next, so once we have completed the examination, we try to localize the site. Then the next thing would be certain investigations. So definitely we need to see how is their blood picture. How is their hemoglobin? Is there how are the blood smear? So how is there different types of red blood cells, WBCs, platelet count, okay, blood grouping, bleeding time, clotting time. prothrombin time, and activated thromboplastin. Definitely not to forget the viral markers. We have to, along with the patient, our safety, that is the doctor's safety is also equally important. So viral markers also, because if any intervention is needed, we need to protect ourselves. Coagulation profile, definitely. And we can take help of certain radiological X-rays of the nasal bones and the CT of the paranasal sinuses, MRI and angiography. So all this depending upon the underlying cause according to the necessity. If there's any granulomatous conditions or systemic conditions, certain specific tests also need to be done. Next, coming to the treatment. So in this treatment, this is the general treatment that is there for the epistaxis, the general measures, the medical treatment, that is what are all the drugs you're going to prescribe, the nasal packing techniques, the catheterization, cauterization, ligation, septal surgeries, embolization, and treatment of the specific causes. So what has been discussed in this slide is basically overall treatment methods that are available to treat a epistaxis case. But let us see what is the strategy that we need to apply. Firstly, when we examine the case, after ABC is done, we are doing the nose examination now. Suppose we are able to directly localize the site. We can see from where it is bleeding. Then, without any other things in mind, we tend to stop the bleeding taking help of a direct therapy. That is, either you take help of a cautery, which is an electrocautery or a radio frequency or a coagulation. These are all the cautery techniques, applying the current leading to coagulation of the blood vessels. Okay, so we apply the bipolar, it will stop the bleeding. And then we have to, bleeding is controlled. We pack the nose for 2 days. And sometimes packing is also not needed. We can just observe the patient for a day. If there is no further bleeding, we can discharge the patient. Suppose if the patient, we are not able to localize the site of the bleeding, then we have to take help of an endoscope. With the help of an endoscope, we try to localize the blood vessel. Suppose still we are not able to localize the site of the bleeding, we take help of indirect methods, wherein we pack the nose first. But still, after doing anterior packing also. So packing is again anterior and posterior. Even after packing the nose, suppose we are not able to the bleeding is not stopped. We tend to resort to posterior packing. Even with the posterior pack, it's not stopping. We take help of Mirosil. In the coming slides, we shall see what are all these. And even with the Mirosil, we can't pack. Then we go for ligation techniques and finally the embolization. So this is the management strategy that we have to adopt for epistaxis case. So in the first 8 general measures, we have to reassure the patient, nothing will happen, counsel them. We have to make them sit, lean forward, pinch the nose up to the bleeding and clotting time, that is for at least 5 minutes. Apply the cold ice pack over the dorsum of the nose, which leads to the reflex constriction, vasoconstriction. Then we'll see for bleeding. That is one first method. Next is the Trotter's method. Basically, we are not adopting this method because in the Trotter's method, this patient is in leaning forward position with mouth open. We allow them to bleed till they develop hypertension. But it's such a danger method. It can lead to coronary thrombosis and also the patient can die. So we are not adopting this technique. We need to have a check on their vitals and also the oxygen, IV fluid, and then the drugs. So what is the medical treatment that we are going to start immediately? Along with the IV fluids, we need to give ethamsilate, which is a hemostatic drug which promotes platelet adhesion and stops the bleeding. If required, if the BP is high, we tend to give antihypertensives also, and tranexamic acid, which is basically an antifibrinolytic agent which stops the bleeding. and vitamin K. And in the nose, we tend to use a cotton plunger which is soaked with a decongestant, and we just put it inside the nose. And also, we can, if you don't have a decongestant, we can take help of a hemocoagulase like water clot. So these are local hemostatic agents which try to stop the bleeding. Along with it, there should be a systemic antibiotic coverage and stop any anticoagulants. So this is medical treatment. So when a patient comes to our OPD, so just our immediate measures would be putting a cotton plunger soaked with a decongestant, and we then observe for bleeding. If it is still bleeding, then we'd have to keep the epistaxis set ready with us with all the cautery, the forceps, the suction catheter, the meroseal packs, the gel foams, and also the local decongestant drops. So if it is bleeding more profusely, we are not able to localize the site, we have to go for a technique called anterior nasal packing, which is done with the help of a ribbon gauze, which is 1 meter in size. So we have to first of all soak this pack either in a liquid paraffin or any antibiotic cream. And in a step ladder pattern, we have to pack the nose. So either we pack the nose in a horizontal or in a vertical. Commonly we do it in a horizontal step ladder pattern. So we take help of a nasal forceps, take this ribbon gauze. First we insert it into the nasal cavity in the floor, and then we have to keep inserting it in a step ladder pattern till we reach the roof of the nose, from the floor to the roof. The pack has to be removed preferably after 24 hours, but maybe we can extend even up to 48 hours, but not more than that, because it can lead to toxic shock syndrome. So a systemic antibiotic coverage is a must when nasal packing is done. So this is the nasal packing. Posterior nasal packing, what we do is we take help of a pack which is called a billow. So with the help of the pictures, I shall explain you this technique of posterior packing. So this is the billow pack, a posterior nasal pack. So we have two threads which is tied to one side and a single one thread on the other side. First we need to pass a catheter. Two catheters are passed in two nostrils, and these catheters are pulled out from the mouth. And we have to attach the two ends of the posterior pack to the ends of the nasal catheters that have been brought out from the mouth. And then we have to push this nasal pack posteriorly from the mouth up into the nasopharynx. And other hand, we are going to pull the nasal catheters from the nose. So the tips of these nasal catheters were tied to the two ends of the threads. So once we pull the catheters, the two ends of these silk threads are brought out individually from the two nostrils, which are then tied at this columella. The single thread that was there on the opposite side has to be freely hanging in the oral cavity, so that when we have to remove the pack, it becomes easy for us. We also additionally have to pack the nose anteriorly along with the posterior nasal. Okay. This is the complete outer nasal. So it's like in the posterior epistaxis, we go with the posterior nasal packing. For anterior epistaxis, we go with the anterior. We can also do this posterior packing instead of the uh, ribbon gauze. We can do it with Foley's catheter as well, wherein we need to inflate the, once after the catheter is introduced, it's brought out from the mouth. We do anterior nasal packing with the ribbon gauze. So this at the level of the nasopharynx posteriorly, the balloon is filled with air. So if at all it ruptures also, if we fill it with water, again there is all possibility of aspiration if it breaks. But if it is air, we don't have to fear for that. The complications of the nasal packing is, so when the nose is packed, So one tends to get epiphora, that is watering of the eyes, because the nasolacrimal duct is blocked from the nasal end. Headache, heaviness, and there can be ear block. There can be a secondary sinusitis and a toxic shock syndrome if the pack is not removed after 48 hours. The other technique, if the nasal pack, the bleeding is not stopping, we tend to use a Mirosil tampon, which is basically uh, a sponge which is dehydrated once, which is inserted into the nasal cavity. Once it is inserted, it is hydrated with normal saline. When it is hydrated, it will swell like this and it puts pressure. So whether it is nasal packing or a Mirosil, the mechanism of stopping the bleeding is applying pressure leading to vasoconstriction of the blood vessels. Thereby, it can stop the bleeding. Okay. So this Mirosil is made up of a material polyvinyl acetate. We can take help of balloon catheters like this, inflate the air anteriorly as well as posteriorly. It applies pressure and stops the bleeding. Cauterization techniques, either chemical cautery or electrocautery. Chemical cautery can be done with 10% silver nitrate or a 50% of trichloroacetic acid. Electrocautery, either we take electrocautery or a radio frequency or a coagulator. Purpose of the cautery is coagulation of the blood. Suppose all these techniques also it's not stopping, bleeding is not stopping, we have to think about ligation techniques. So we can ligate external carotid artery or an internal maxillary artery, ethmoidal artery, Crespal, which is the transnasal endoscopic sphenopalatine artery ligation. So these are few ligation techniques which we can adopt in case of epistaxis, not controlled with packing and Mirosils. In case of deviation of the nasal septum, septoplasty has to be done to remove the spur. Thereby bleeding can be controlled. The last technique where bleeding is not controlled with any of the above methods, we have to resort to embolization of the blood vessels. So we have to embolize the maxillary artery with particles like polyvinyl alcohol, tungsten or a steel microcoils. But always there is a risk of cerebral thromboembolism with this technique. In hereditary hemorrhagic telangiectasia, a technique called septodermoplasty is done, wherein the anterior part of the septal mucosa is excised and replaced with a split skin graft. And the bleeding sites are controlled with laser, either argon, KTP, or NDF. So that was about epistaxis. To end this session, let us just summarize few key points. One has to keep in mind the local and the generalized causes of epistaxis. The commonest cause in children being the pricking of the nose. An adolescent boy, it is for angiofibroma and hypertension, commonest cause in the elderly male. So if it is an anterior epistaxis, the little area is the commonest point. If it is posterior epistaxis, it is the Woodruff's plexus. Proper evaluation, proper extraction of the history is very important in knowing the cause, and then followed by ENT local examination and general examination and blood investigations. So reassurance and just pinching of the nose and applying ice packs, along with it giving IV fluids, ethamsalate and antibiotics, and also the local nasal decongestant drops. This is the first general techniques that we adopt. Once we examine the nose, so bleeding point localization, after the general measures are done, but still it's bleeding, we have to go either with direct or indirect. So indirect method where we cannot localize the bleeding point, we take use of packs, ribbon gauze, anterior and posterior nasal packing, or a polyvinyl acetate, Mirosil tampons, or a balloon catheter. Bleeding point is localized, then directly apply the chemical cautery or an electrocautery. Not controlled, go for ligation techniques, any septal surgeries. The final would be embolization. Thank you.